Bismillah ar-Rahman ar-Rahim. Hello everyone. My name is Sahar Mamoon. I am a clinical pharmacist having my MSc degree from University College London. I am a board certified pharmacotherapy specialist and I have got an MBA degree specialization in total quality management. I am your colleague, and inshallah today together we are going to go through how to manage the complications of chronic liver failure. Okay, so it's going to be a brief talk. I will go through. So our learning objective or our outline for today's presentation is going to be we are going to start off by ascites, and then we will go through to know more about spontaneous bacterial peritonitis, that is SBP, and then we are going to go to hepatic encephalopathy, and before the last Oesophageal Varices, and lastly we will conclude with clotting abnormalities. Okay, so basically, as we all know, that liver is being a largest organ in the body. It has a main role in maintenance of health and in maintenance of homeostasis in the body homeostasis. So we will observe that most of the complications today I am going to talk about, it is more or less is due to a defective function of the liver. So when we know what are the functions of the liver, if we can remember from the college, it has got a synthetic function, it has got metabolism function, and it has got an excretion function. So today, most of the complications which we are going to have is more or less is due to its pathogenesis originates from a defective function. For example, in the ascites, we are going to know that it is one of the contributing factors or one of the contributing causes of ascites is due to defective synthesis of albumin. And on the other hand, in hepatic encephalopathy, we will know that when the liver is failing, there is no metabolism and excretion function. The liver is not functioning properly in these two aspects. So, and this affects the ammonia level. So the ammonia level will increase and it will cause hepatic encephalopathy. And for example, again, having one of the complications, clotting abnormality, we will know that it is due to the defective synthesis of clotting factors. So more or less, to conclude this part, if we know the main functions of the liver, so subsequently, if the liver is failing, that means it's not doing its proper action. Okay, so let's start. What is ascites? Ascites is an accumulation of fluid in the abdominal cavity secondary to increased resistance within the liver. Okay, so it's basically in Arabic is istisqa. Okay, it is one of the most common complications of liver disease. It occurs very early in the disease state, in the chronic disease state. So what causes this retention in the abdomen, or what causes water to retain in the abdomen? So more or less it's a controversial. However, some of the contributing factors might be cirrhosis, which is advanced liver disease, when there is an abnormal in the architecture of the cells of the liver are being abnormal. Portal hypertension and reduction in albumin, as I have previously mentioned, that lead to creation of pressure gradient. So these all they include like a pressure gradient. There is places which is high in pressure and places which is low in pressure, and this gradient will help water to move to one side and then it will retain in the abdominal cavity. So what is my aim of the management? Obviously is to mobilize this intra-abdominal fluid and to prevent more accumulation of fluid in the abdomen. So when we so what are the management approaches in ascites? We have got one of two approaches, either the non-pharmacological approach or the pharmacological approach. Okay, so the pharmacological approach here, I don't just mean drugs, I mean anything or any procedure, any drug which is going to help me minimize the water which is retained in the abdomen. That is to say, the paracentesis and the tips. These are two procedures. They are not drugs. And then the first line will be diuretics. When we come to the non-pharmacological approach, we have got fluid and salt restriction and the bed rest. When I talk about fluid and salt restriction, I am talking about an amount of less than 2000 milligram per day of sodium, and I am talking about less than 1.5 liters per day of fluids. Okay, so let's go ahead and have a look at the pharmacological management. As I have previously mentioned, that the first line management in ascites is diuretics. Okay, so what is the first line agent? Spironolactone. Unlike hypertension, in hypertension we used to say that furosemide is the first line agent, and then we will add spironolactone if needed. No, here in ascites we have to bear in mind that the first line agent is spironolactone in a dose of 100 milligram per OD, and then I titrate according to what? According to the fluid, the amount of fluid which is being lost. So here my measure of therapy, how would I measure if I am the effectiveness of the therapy? By weighing my patient, by weighing the amount, by weighing his weight, sorry, and by measuring the amount of urine output. Okay, then if what happen if I reach a maximum of 600 milligram per day of spironolactone? Then I will add a furosemide, which is a loop diuretic, in a dose of 40 milligram per OD. Oh, that once daily. Okay, so as with all therapy, as we all know that diuretics have complications, have side effects such as hyperkalemia, hyponatremia, encephalopathy. Okay, and no, here we have to know that generally the diuretics in when treating ascites, when treating ascites by diuretics, I have to monitor my patient, because the diuretics being used in encephalopathy, it predisposes the patient to encephalopathy, which is another type of complication I will be talking about later. Okay, so so basically, if the side effects are, I am suspecting hyperkalemia, hyponatremia, so I have to put my patient in a close monitoring of his electrolytes, potassium and sodium, mostly we can say every day while he is in inpatient. Okay, so that is the pharmacological part. Okay, so and I say that there are some procedures which are used to drain the amount of fluid which is in the body, in the abdomen, and one of the procedures is called paracentesis. Okay, so what is paracentesis? As we can see in this slide, this is like a patient with ascites in his abdomen. Okay, and they are doing him the procedure called paracentesis. What is paracentesis? Paracentesis is a procedure at which a fluid is drained. I am draining a fluid from here, okay, but at the same time I am replacing him with a colloid. I am replacing him with albumin. Why? Because I don't want this patient to be hemodynamically unstable. So I have to, as long as I am replacing some of the fluid from his abdomen, I have to supplement him with something which is to maintain the same pressure gradient, so that the patient won't like enter in a hypotension or something, or hypovolemia. So as you see here, this is the ascites, this is his abdomen, this is the procedure. The procedure normally being done with a needle. I insert a fine needle. It's quite minor procedure, it's not a big procedure, and then I drain the fluid out of his tummy, or I draw the fluid out of his abdomen, and then I replace it with albumin. How much do I replace? For every 100 ml, for every 2.5 liters removed, I am replacing it with 100 ml of albumin. That is to say, every 2.5 liter of ascitic fluid being drained, I have to replace it with 100 ml. Okay, when do we use paracentesis? When there is a diuretic resistant ascites, that is ascites which is not responding to diuretics. When there is a severe ascites, a refractory ascites that keeps coming again and again and again. Okay. So the third procedure, the third management approach in the pharmacology of the ascites is the TIPS. The TIPS is a procedure called transjugular intrahepatic portosystemic shunt. That is, I am creating a shunt. Okay, I am placing a metal stand to create a shunt that reduces the portal pressure. Okay, if we can see here in this picture, what I am trying to show you, there are some of the veins, okay, which have entered in the varices. There is like a high pressure. Okay, so what I am trying to do, I am trying to create a bypass in order to reroute the blood around the scarred liver. Why? Because if the veins start closing, okay, so the bloodstream is not moving functionally. I mean, it's not moving straight away. يعني إذا هي أنا هشرح بالعربي. إذا الفينز هي مقفولة، أو أنا أساسا عندي في السيروزز إنه بكون الخلايا وضعها مش طبيعي، أو الخلايا شكلها مش طبيعي، فده بيقوم بيخلق لي إنه بيؤدي إنه محمد بيؤدي إنه البلد ولا الدم ما يكون منساب بطريقة طبيعية. فهنا أنا بحاول أخلق للبلد، أخلق له روتس أو بخلق له ممرات على أساس إنه هو يقوم to pass by it, as you can see here. Okay, so this is done by placing a metal. A metal is placed, and then the blood can find its route, so it can flow smoothly. Okay, so that is the tips. Okay, it's being used both in variceal bleeding and in refractory ascites. Okay, so coming to the second complications, which is spontaneous bacterial peritonitis. What is this? It is simply simply an infection in the ascitic fluid. Okay, the patient is ascitic. He has got some fluid in his tummy, and this fluid is getting infected. As we know that water is a good media of the growth of microbial growth. So what are the common pathogens? We have a strep staph, which are gram positive, and we have E. coli, which is gram negative. How would I diagnose it? Normally, they do an ascitic fluid tap. That means they take a fluid sample and they do like investigation on it, and if the neutrophil count is more than 250 cells per cubic milliliter, that means the patient is having a spontaneous bacterial peritonitis. What is the first line therapy? The first line therapy is third generation cephalosporin, which is cefotaxime. Okay, when do I need to add albumin? Albumin is generally needed in either of these three conditions: if the serum creatinine is low, if the blood urea nitrogen is high, or if the total bilirubin is more than 4 mg per deciliter. What other antibiotics can I use? A broad spectrum antibiotic, Comexoclaz, and which is basically amoxicillin plus flavunate, and again for prophylaxis, norfloxacin can be used. Okay, so as we all know that one of the main functions of the liver is excretion, metabolism and excretions, and one of the agents which depends on the liver for its excretion is ammonia. So in hepatic encephalopathy, the liver is failing, there is no excretion of ammonia, and thus there is accumulation of the ammonia and nitrogenous product in the body. So, and when this ammonia and nitrogenous product start accumulating in the body, it will pass through the blood-brain barrier. And then imagine what if a foreign substances enter the brain, it will generate or it will result in a neuropsychiatric disease, which is the hepatic encephalopathy. So it's a metabolic disorder in the CNS. It's mainly due to the translocation of the ammonia. It helps in grades from grade 1 to grade 4. Okay, and it starts by simple confusion and then it can progress to coma. Risk factors of hepatic encephalopathy: the GI bleeding, the hypokalemia, constipation, sedative drugs will contribute to hepatic encephalopathy, and the diuretic use, as I have mentioned, that the diuretic use can predispose the patient to hepatic encephalopathy. And again, the TIPS procedure. Surprisingly, the TIPS does contribute to hepatic encephalopathy. So, what is my management? Is to reduce the ammonia and nitrogenous compound. It's brilliant. Well, if I can reduce its production. I can decrease its translocation into the brain. So, what are the drugs used? Lactulose, which is antidiuretic, antidiarrheal agent, is being used. And this how does it work? It works by reducing the pH and acidifying the chlorine content. And again, if I want to reduce the number of bacteria which is producing the ammonia, or urea is producing bacteria, I have to use an antibiotic, which is metronidazole or neomycin. Okay, so coming to Oesophageal Varices. What is Oesophageal Varices? Oesophageal varices, it's a massive upper GI bleeding from the ruptured oesophageal varices. Okay, as we know, there is a portal hypertension. Usually, the ascites or cirrhosis is accompanied by portal hypertension, and this portal hypertension creates there is the portal veins. The portal veins are under a huge amount of pressure, and when this pressure is just increasing and increasing, the varices, which is coming from the veins, it will rupture and then it will bleed. So my aim is to reduce or slow down the immediate loss and to treat the hypovolemia and prevent recurrent bleeding. Why? Because the patient is bleeding, so I don't want this patient to enter into a hypovolemia, which is going to complicate his condition. Okay, so what is the pharmacological? So mainly, my mainstay of treatment is resuscitation or fluid replacement. Okay, I have to put in my mind here, I am replacing with a colloid. I am not replacing with a saline, because the saline is going to deteriorate my patient. I have to bear in mind this is a patient possibly with ascites, and so a saline is a source of water, and it's going to aggravate his symptoms or aggravate his ascites. Okay, so and then I have to give a vasoactive therapy, basically to help the bleeding. I have to give a vasoconstrictor, which is going to vasoconstrict or vasoconstrict. Again, I have to give a vasoconstrictor, terlipressin and glyceride plus or minus glyceride trinitrate. Okay, however, I have to be cautious because these are vasoactive agents in ischemic heart disease. I have to be in caution with ischemic heart disease patients who already are complaining of vasoconstriction in their heart. So other drugs to be used are somatostatin infusion or octreotide. Okay, so this is just a slide to show you how much can the veins, subhanallah, ممكن هي تنتفخ مئة درجة. Okay, so this is when I am talking about pharmacological treatment. Again, as we have mentioned with ascites, here there is a procedure. There is endoscopic therapy that is to be done. The first one is called sclerotherapy. Sclerotherapy is just like injecting, if you can imagine with me, I am injecting a vasoactive substance straight away in this very big fat veins. So I am injecting it inside. I am injecting a sclerotherapy. I'm injecting a vasoactive agent. Variceal ligation اللي هي الربط. I am بالعربي بربط الفاريسز اللي هي طالع منها الدم أو اللي هي اللي بتنزف، أنا بقوم بربطها. Balloon tamponade is when I am inserting a balloon. This balloon is huge, as you can see, and I am pressing on the varices which is bleeding, and by this I can prevent the bleeding. Okay, so what guarantee that the bleeding won't happen again, or how would I prevent the rebleeding? Radiation at regular interval, and putting of my patient in non-selective beta blocker, that is propranolol, in a 40 milligram dose BD, and then I have to adjust the dose according to heart rate. Okay, lastly but not leastly, I have got the last complication, which is clotting abnormality. As we know that liver has a synthetic function, so some of the clotting factors are being synthesized by the liver. So so what happens here? There is a defective in the clotting factor synthesis. Okay, there is a prolongation in the there is a prolongation in the INR. Okay, so there actually not only there is a defective synthesis of clotting factors, but there is also another mechanism by which increases the increasing bleeding tendencies in chronic liver failure. That is defective bile salt excretion and hypersplenism. And in hypersplenism, if the spleen is being enlarged, so there is effective synthesis of platelets. If there is no platelets, so that means the patient is at high risk of bleeding. So these are the three mechanisms that increase bleeding tendency in patients with chronic liver failure. How would I manage it? I manage it by giving IV vitamin K. Bear in mind that studies have shown that the IV dosage form is more effective than oral. How much am I giving to my patients? I'm giving a 10 milligram daily for 2 days. Okay. So if there is a bleeding tendency, so it's more sense or more logic that is to try to avoid drugs which contribute in the bleeding tendencies. That I'm talking about anticoagulants. I'm talking about NSAIDs and stuff. So I have to make sure my patient does understand that he's not getting any over-the-counter drugs which is going to aggravate his bleeding tendency or putting him at high risk of bleeding. Okay, I hope you find this useful. أتمنى إنكم تكونوا استفدتوا منها. It was a very brief talk just to help you guys in having like or refreshing your knowledge about the complications of liver failure. Thank you very much, and this is a quote I love. Keep learning to keep winning. If you stop learning, you stop creating history and you become history. Thank you very much.